Hi, thanks again for coming. I'm just going to introduce our speakers quickly in alphabetical order, of course, starting with Dr. Gottlieb. Dr. Scott Gottlieb is an alumnus of the Mount Sinai School of Medicine, that is before the name change, and also an alumnus of the Mount Sinai Internal Medicine Residency Program. He's currently a professor of internal medicine at NYU Tisch and a resident fellow at the American Enterprise Institute in Washington, D.C. He previously served as the FDA's Deputy Commissioner, the FDA's Director of Medical Policy Development, and from 2003 to 2004 as Senior Advisor to FDA Commissioner Mark McClellan. During 2004, Dr. Gottlieb also served as a Senior Advisor to the Administrator of Medicare and Medicaid Services, where he supported the agency's policy work on quality improvement and coverage and payment decision-making, particularly related to new medical technologies. Since completing his training, Dr. Gottlieb has authored more than 300 articles for leading medical journals, the Wall Street Journal, the New York Times, USA Today, and Forbes magazine. Moving on to Ms. Sally Pipes. Sally C. Pipes is President and Chief Executive Officer of the Pacific Research Institute, San Francisco-based think tank. Yes, ma'am. A San Francisco-based think tank founded in 1979. In November 2010, she was named the Taub Fellow in Healthcare Studies. In 2008, she founded the Benjamin Rush Society as a division of PRI and will be president and chair of BRS when it becomes an independent nonprofit organization later this year. Prior to becoming president of PRI in 1991, she was assistant director of the Fraser Institute based in Vancouver, Canada. Ms. Pipes addresses national and international audiences on healthcare issues. She writes a weekly healthcare column called Piping Up, it's a play on her last name, for Forbes.com, and has authored several books on healthcare reform, including Miracle Cure, How to Solve America's Healthcare Crisis and Why Canada Isn't the Answer, The Top 10 Myths of American Health, The Truth About Obamacare, and The Pipes Plan, The Top 10 Ways to Dismantle and Replace Obamacare. Moving on to Dr. Rodberg. Moving on to Dr. Rodberg. Leonard Rodberg, PhD, is a professor and chair of urban studies at Queens College, CUNY. He holds a PhD in physics received from MIT in 1957. Along with his late wife, Joanne Lukamnik, he was one of the founders of Physicians for a National Health Program. He began his professional life as a nuclear physicist, but has obviously strayed a bit. He served as director of the Science Policy Office in the U.S. Arms Control and Disarmament Agency and resident fellow at the Institute for Policy Studies in Washington, D.C. He has been involved in the struggle for healthcare reform since 1974, when he led the development of the Dellums Health Service Act. He has served on the board of the New York Metro chapter of Physicians for a National Health Program for a number of years, and he's also treasurer and research director of the chapter. He also created and directs the Infoshare community data website, www.infoshare.org. Dr. Elizabeth Rosenthal recently retired from her Mamaroneck practice of dermatology after 35 years. She continues on the clinical faculty of the Albert Einstein College of Medicine. For the past 5 years, she has been an active board member of the New York Metro chapter of Physicians for a National Health Program. Speaking and writing on healthcare reform for the past several years, she's a passionate advocate of an expanded and improved Medicare for all. She's a graduate of Smith College and NYU Medical School and is diplomat of the American Board of Dermatology. She lives in Larchmont with her husband, who is also a physician, and they were parents of 3 grown sons. And finally, our moderator, Dr. Lawrence Kleinman, who works here at Mount Sinai. Dr. Kleinman graduated Rutgers University with a BA in history and moved on to Wake Forest Medical School, where he graduated in 1983. After receiving his MD, Dr. Kleinman spent 4 years working with the National Health Service in Bridgeport, Connecticut, after which he received the Robert Wood Johnson Fellowship to study health policy at UCLA. He simultaneously studied for an MPH there, and Upon completing his Robert Wood Johnson Fellowship, Dr. Kleinman moved on to the private sector to head the Disease Management Division in Value Health Sciences, a Santa Monica-based startup. He moved on to head his own startup called Quality Matters, after which he came to Sinai. At Sinai, Lawrence C. Kleinman is the Vice Chair for Research and Education and Associate Professor of Health Evidence and Policy and Pediatrics. He is also the Principal Investigator for CAPQUAM, the Collaboration for Advancing Pediatric Quality Measures. So just a quick rundown of our debate format. We're operating in an Oxford-style debate, which means that Ms. Pipes and Dr. Gottlieb will make 5 minutes of opening remarks, after which the other side will make 8 minutes of remarks, followed by 8 minutes of remarks, another 8 minutes of remarks, with a 3-minute rebuttal by Dr. Gottlieb and Ms. Pipes to wrap it up. So I hope you enjoy the debate, and thank you again for coming.
Good evening. With this, I'd like to invite Dr. Gottlieb to begin with 5 minutes of the proposition.
Thank you, and it's a pleasure to be back here at Mount Sinai. I'm going to speak in favor of the proposition, and I want to focus my initial remarks on Medicaid, and Sally's going to talk a little bit more about the Medicare program. The reality is that both programs, in my belief, are failing to fulfill their compact with those who depend on them. And Medicaid in particular is failing to fulfill its compact with the elderly and the poor and the disabled. I want to focus on Medicaid because in many ways I think it's in an advanced state of where we are heading when it comes to Medicare. And it's a version of the sort of coverage that I think many of us can expect as the new state-based exchanges take shape under the Affordable Care Act this fall. In fact, the insurers who are going to be providing coverage in those exchanges have already said that they expect those plans to look a lot like Medicaid, and they're referring to them publicly as Medicaid Plus. So we need to ask whether we think Medicaid is fulfilling its compact to the poor and disabled and whether the program is working. And I would say that right now it's not. Medicaid promises expansive benefits, but in practice, patients often have a hard time accessing care in good settings or accessing it at all. This is especially true when patients need access to outpatient specialty care. Now, I know that this varies state by state, and I know New York has generous benefits and subsidizes the program, but in many parts of the country, this is the reality. And the result is that when you look in the medical literature, there are literally hundreds of articles, I apologize for that, there are literally hundreds of articles that look at Medicaid patients against other insured types and find poor outcomes based on insurance status alone when you try to control for other variables, things like socioeconomic status and other things that might affect health outcomes. Now, I know that these studies are hard to do. I've written a compilation of some of these studies. I know any one of these studies can overstate the findings, and I know it's hard to control for the other factors that contribute to poor health outcomes. But when you have literally hundreds of studies pointing to the same thing, it's hard to ignore the totality of that data. Now, why is this so? What's happened over time is that owing to federal rules, the scope of benefits that Medicaid has to provide programs inside the states has continued to expand, and the number of people and the communities of people that it's mandated to cover has grown as well, but its budget has not grown in proportion to that expanding mandate. And so what's happened is reimbursement has been driven down in the program, and it's effectively become a hollowed out benefit. Now, I would put forward, I don't think that this is moral. I don't think that we should settle for this. The program provides an important basic backstop, but should we really be comfortable with giving people what is too often an empty promise when it comes to their health? Medicaid is literally visiting indecencies, in my view, on the poor. The Affordable Care Act compounds this by expanding Medicaid still further while doing very little to shore up the program, and in fact takes people off of private coverage that they currently get and puts them into the Medicaid program. This is going to be true of children on CHIP who get private coverage through the CHIP program who are between 100 and 133% of the federal poverty level, so a family of four earning about $30,000 a year. A lot of those kids currently get private coverage in the CHIP program. They will all be put into the Medicaid program, as well as dual eligibles. Senior citizens who have access to both Medicare and Medicaid will now be turned over to states and in most cases are being put into the Medicaid networks inside their states. When it comes to Medicare, we're starting to see some of the same things that we've seen under Medicaid. The benefit essentially start to get hollowed out as reimbursement gets driven down and rules get imposed on what people can and can't have access to. And for both of these programs, one thing is for sure. Today's benefits will not be sustainable in the future. All of the estimates on the true cost of these programs show that they grow enormously over the next decade, and they just won't be able to be funded by any reasonable tax burden that we'll be able to come up with. And so the most likely outcome is that benefits are going to continue to get reduced in the future. Even while we promise expansive benefits, the actual ability to access that coverage is going to continue to get reduced. Medicaid, in my view, shows what can happen when Washington doesn't keep the promise it makes to people who depend on these kinds of benefits. And I think we owe it to the people who access Medicaid today and those who won't be able to get access tomorrow under an increasingly strained system to confront these challenges. That means addressing how these programs are structured. Certainly, there are structural flaws in them and how they operate. It also means addressing the policy ambitions that have made these programs fail. For too long, many of us, I think, have been romanced by the idea that Medicaid can provide a universal safety net to the poor, that we've really neglected the health coverage that the program is really delivering and the indecencies it visits on the people who are part of it.
Thank you very much. And I believe Dr. Rosenthal is going to go first for the other side, and we'll begin and have 8 minutes.
Okay, you said it's failing, but you didn't say anything about how you're going to provide care for the poor in another way. So it's hard for me to rebut what you say, because I don't think that Medicaid is doing a wonderful job either. But I think Medicare is doing a better job, and I think that Medicare is not the problem. Medicare is the solution. The private sector is not able to, the privatization that's happening in Medicare now is not helping things. Medicare was originally a totally public program, privately delivered, and it's been serving us very well for 45 years. And when it came into being, Medicare lifted many elderly people out of poverty. And the reason that Medicare is so much better than Medicaid is that Medicare is for everybody, not just for the poor. And poverty programs are the ones that always get cut, because the people who receive the benefits of these programs have no political clout whatsoever. So the first thing that is always cut is Medicaid. I feel that Medicare is a solution, but we have to improve it, and we have to expand it to include everybody. We have medical apartheid in our country right now. Either you're in the Medicaid program, which does deliver care. It's a whole lot better than nothing, but I agree that it doesn't keep its promise. It pays very poorly to physicians, except if they're practicing in a clinic situation, so that it's very hard for Medicaid patients to find doctors who will accept them. And I know that when I was in my private practice, if I accepted the payment of Medicaid, I couldn't support my practice. It was cheaper, it was better for me to see the patients for nothing than to spend the money to do all the paperwork to get the very poor reimbursement. So, but I think the way to fix it, so you didn't say anything about the way to fix it. To me, the way to fix this is to get the private for-profit insurance companies out of the picture. They are what's causing a huge amount of layering of a whole extra layer of expense, administrative expense, because what do they have to do? They are in the business to make money, so they have to provide a return to their shareholders. They have to pay huge salaries to their CEOs. They have to do a lot of marketing, because each company wants to get their share of the market. And they have to spend a lot of time telling people, no, you can't have this, and no, you can't have that. So they spend enormous amounts of money, administrative costs, hiring all these people whose job it is to not deny care, because inherently there's a conflict of interest. In order to make money on for-profit insurance, you have to collect the premiums and pay as little for health care as you possibly can. That's the way you make a profit. You can't make a profit insuring sick people. You can only make a profit insuring healthy people. That's why originally a lot of the companies, the private companies that got involved with Medicare, they dropped out because they found that they couldn't make a profit because the Medicare population is actually sick and they require a lot of medical care. And we can compare the for-profit Medicare as Medicare Advantage, and in the Medicare drug program it's much more expensive than straight Medicare. And the Medicare drug program, one of the things I do in my volunteer work for Medicare Rights, which is a group that helps people navigate through the maze of Medicare, and I advise seniors on how to do this. And I have a bunch of papers here which shows all the different programs you can choose. If you want to get a Medicare drug program, you have in my county in New York State, you have 17 different plans to choose from. And it's very, very difficult for people to figure out which one is the best. Same thing goes for the Medicare Advantage plans. And when you compare them, the Medicare Advantage plans with straight Medicare Advantage plans cost 14% more than straight Medicare. So if we want to really take care of our people and not take care of the corporations that they don't actually provide health care. They make a profit by managing health care, but they don't actually provide it. The best way to do that is to have a single payer plan that covers everybody with no copays, no deductibles, and a very standard package of medically necessary benefits that everybody gets. And there shouldn't be two plans, one for poor people and one for everybody else. We should all have one plan. And if we did that, we would save $400 billion a year in administrative costs and be able to cover everybody. So although I think Medicare and Medicaid need to be changed, I don't think they need to be eliminated, and I certainly don't think that the solution is leaving them to the mercy with the predatory practices of the private for-profit healthcare industry. We have seen in every possible way that we can compare the private to the public, be it nursing home, hospices, whatever. It's always more economical, the public way, and the care is even better. So I feel that, as I said originally, Medicare is not the problem, it's the solution. It's the American solution for American health care.
Thank you very much, Dr. Rosenthal. And now I would invite Ms. Pipes to pipe up for 8 minutes.
Pipes is an odd name, so you can do a lot with it if you want to make fun of it. So, oh, sorry. Yes. So I am in favor of the proposition. In 1965, under President Lyndon Johnson, Medicare and Medicaid became law. Seniors became eligible for Medicare at age 65, and Medicaid was available for low-income Americans. Back in 1965, the average life expectancy of an American was age 65. They predicted that Medicare in 1965 would cost about $3 billion, which is what it cost. And they also predicted, this is prior to the Congressional Budget Office, that Medicare would cost $12 billion by 1990. In effect, Medicare in 1990 cost $110 billion, almost 10 times what they had predicted. Medicaid, as Scott said, is, in addition to covering low-income people, covers the disabled and dual eligibles. 45 years later, the Affordable Care Act, the Patient Protection and Affordable Care Act, was signed into law on March 23, 2010. It's almost celebrating its third anniversary. The president had two main goals for healthcare reform: universal coverage and bending the cost curve down. It is my belief, in looking at numbers, that neither of those goals will be achieved under the Affordable Care Act. And of course, starting next year, 2014, there will be a number of changes to both Medicare and Medicaid. The Congressional Budget Office has said 12 million people will be added to Medicaid, in addition to the 50 million people who are already on Medicaid. And to qualify, as Scott said, you have to be at 133% of the federal poverty level or below. This year, the Medicaid eligible rate income for an individual is $15,850. The cost of Medicaid is $485 billion a year. And we have under Medicare about 48 million Americans who are covered under Medicare, and about 14.5 million of them are people who are, as Elizabeth said, under the Medicare Advantage program. I think there's going to be tremendous pressure put on Medicare, the program that already costs close to $500 billion a year. In order to fund the expansion of Medicaid, Medicare is going to be cut by $716 billion over 10 years. This is definitely going to result in seniors having less access to doctors and less care. In other words, care will be rationed. Three additional ways to cut Medicare under the Affordable Care Act. One is IPAB, the Independent Payment Advisory Board. The second, ACOs, or Accountable Care Organizations. And the third is PCORI, the Patient-Centered Outcomes Research Institute. IPAB is a panel of 15 members who will be appointed by the President. To date, still no one has been appointed to IPAB, which makes me think there is a lot of bipartisan support for repeal of IPAB. But if federal spending by doctors and hospitals on Medicare patients exceeds the average consumer price index growth between 2014 and 2018, costs must be reduced. IPAB, of course, cannot ration care, it cannot cut benefits or increase seniors' premiums or introduce cost cutting. So it is my belief that the cuts will be made to doctors and hospitals, resulting in ration care with doctors dropping patients. ACOs are another delivery model offering doctors and hospitals financial incentives for providing good quality, coordinated care to Medicare beneficiaries while holding the cost down. As of January this year, the Health and Human Services have said 250 accountable care organizations have been set up. ACOs will benefit from savings from the government if costs are lower than projected. If higher, doctors and hospitals will have to pay costs back to the government. It is my belief that doctors and hospitals will deny care to seniors if they feel their costs are going to exceed that ceiling. In other words, in my mind, ACOs are a giant HMO, which of course the American people rejected in the early 1990s. The Patient-Centered Outcomes Research Institute, I believe, will ultimately decide, just like NICE in the UK, whether treatments and procedures are cost-effective as compared to medically effective. The defenders of PCORI say that they cannot dictate coverage, mandates, or reimbursement rates. But that doesn't mean that private insurers or public payers like Medicare and Medicaid can't use PCORI's research and data to adjust the coverage for seniors or reimbursement of doctors. I believe this is another way to cut costs in Medicare while rationing patient care. Scott talked a lot about Medicaid, but just so you know, under the Affordable Care Act, when the Supreme Court looked at the constitutionality of the Affordable Care Act, there was a 7-2 decision saying that the federal government cannot cannot force the states to expand their Medicaid programs. While no one can deny that there are problems in American health care, a system that empowers doctors and patients will solve them, not increasing the role of government in our healthcare system. And in my concluding statement, I'm going to talk about the ways to reduce the cost of Medicare and Medicaid while making those programs work for the people that need them. I'm going to talk also about, Elizabeth, I grew up under a government-run healthcare system, the single-payer system in Canada. We can talk about how care is rationed there, long waits for care, and lack of access to the latest treatments that are available. So thank you.
Thank you very much. And not wanting to not be an equal opportunity punter, spare the Rodberg, spoil the debate. Dr. Rodberg, if you would take your 8 minutes.
Bad. Okay. This country does face a serious cost problem in the healthcare field and an access problem. And what I want to talk about is why it does and what the solution is. I think Ms. Pipes at the end, very end, got to what her overall position is that there'd be less government. I want to counter that. Those of you that have been to presentations by Physicians for a National Health Program, PNHP, know that we always use slides and data, but not in this format, so you'll have to use your imagination. So what I want to do is imagine a graph in which you compare the passage over time of the cost of healthcare for a variety of countries in the world. And if you look at every country, every major country but the United States, what you see is basically a flat graph at about 8 to 9% of gross national product. Whereas for the United States, what you see is a graph that climbs today to 17%, and in a few years to 20% of our gross national product will be spent on healthcare. If you do another graph, which I show in my slides, which is a bar graph showing the percent of the population that has insurance coverage for every other country, every other major industrial country, the graph is basically 100%. In the United States, it's 83%. That is, 50 million people in the United States today have no insurance coverage for a whole year. And under the ACA, the Affordable Care Act, Obamacare, that number will remain at 30 million. So we have a cost problem and an access problem. We are an outlier in the world. Now, you're medical students. Imagine you're in an emergency room and in comes somebody who is quickly diagnosed with food poisoning, so who's just come from a party. All right. So one of the things you do is you go and check with the other people who are at the party. Did they get sick? And if they didn't, you try to figure out what did that person eat that gave them food poisoning. So what I want to do is say, take that analogy, look at the rest of the world and ask yourself, what is the poison that the United States is eating that is leading to this cost divergence, where our costs are going this way and everybody else's costs are down here and flat? And the answer is every other country has a system in which the government either funds the program, such as Canada, Britain, Taiwan, or the government regulates the program so that the costs and the purchasing of medical supplies and equipment, the fees are regulated by government. They're not set necessarily by government. They're regulated through a negotiation process. In the case of physicians, the Physicians Association negotiates it with the government. So the problem in this country is we have relied on the market. The market is the poison that we have. And the Affordable Care Act doesn't change that. In fact, it extends it. It provides a subsidy for more people to buy private insurance. It will not solve the problem. Even its advocates admit that the cost of health care in this country will continue to rise at roughly 6% a year, whereas the average cost of, in good times, of incomes and costs is about 3%. In other words, healthcare will continue to eat up the rest of the economy unless we change the way we, in fact, pay for healthcare. Now, 50 years ago, Kenneth Arrow wrote an article which is widely seen to be a classic published in the American Economic Review, in which he showed that the market did not work. Market, as understood by economists, did not work in the healthcare system. Partly because of uncertainty, because when someone is sick, you don't know what the treatment is going to be until you've done a complete diagnosis and until time has passed. Partly because pricing doesn't work. There's a recent article in the special issue of Time magazine that shows it very, very graphically that the pricing structure we have in this country is literally crazy. Every hospital bills differently for the same procedures. There's no way in which a market can work under this kind of a situation. The lesson I draw from this is we ought to look at the rest of the world. Taiwan, when it faced a similar problem as we, that is, half its population had no insurance and its costs were rising. It looked at the rest of the world, chose the best, and decided on a single payer system, that everybody should be in a publicly funded system where everyone would have access and prices would be regulated. That's the direction we should go. We call it Medicare for All. It's in legislative terms, it's the Conyers bill in the federal House of Representatives, and in New York State, it's the Gottlieb bill for a New York health program. And I think that the lesson from the rest of the world, if we weren't so proud and narrow-minded and looked at the rest of the world and learned from it, the lesson from the rest of the world is that this kind of program will address the problem. And we have, as Dr. Rosenthal pointed out, we have 45 years experience now with Medicare, and public Medicare works. Its costs don't rise as rapidly as private insurance costs and private medical care costs do, and it provides good care, and more than people who are in their 50s and 60s can't wait to get to Medicare, because they will then be assured of having the access to care that now they aren't sure of. Thank you.
Thank you very much. And now I invite Dr. Gottlieb for his 3-minute rebuttal.
Well, I think you're maligning a market that a lot of conservatives would say doesn't really exist. And it comes down to a question of whether or not you think the problems exist in spite of Medicare or because of it. And I think a lot of conservatives would argue that a lot of the problems in the healthcare market as we know it exist precisely because of the intrusive impact of Medicare, which does set prices and does set fees and does heavily regulate the provision of care. I just want to, I don't know if I'm going to have enough time for this, but I wanted to comment on the profit motive in medicine, Medicaid, and then just the future of Medicare. It's a lot to bite off in 3 minutes. On the profit motive in medicine, there's a lot you can say about it, but one thing I would say is that a lot of the innovation that we take for granted in delivery of medicine came out of for-profit companies that were seeking returns on capital. Outpatient dialysis, home hospice, skilled nursing facilities, LTACs, outpatient rehab, HMOs, all of those started as venture-backed companies by entrepreneurs that were seeking profits. And in many cases, they were seeking to move patients from high-cost settings of care to low-cost settings of care, because under the Medicare system, that's the only way you can profit. Move a patient from a high-cost setting of care into a low-cost setting of care and bill under the old code. And that's how people learn to profit under the Medicare system. You can't earn excess returns on invested capital anymore doing business with Medicare. Literally, the program regulates margins and profitability. And because of that, you've seen venture capital flows dry up to almost zero going into healthcare services. All the money that's going into healthcare these days from investors is focused on consolidating healthcares from buyout shops. So I wonder where the innovation is going to come from in the future in the delivery of care. On Medicaid, I think few would argue that there's a profit motive in the Medicaid program, although there is a very strong profit motive in the program. And the program is really provided by a lot of contractors that work for state agencies. In terms of reforming it, I think there's a number of things you can do. You can give states flexibility on who they choose to cover and the kinds of benefits that they choose to provide so that they can target benefits to the most appropriate people and target resources to people who need it the most. Right now, federal rules largely prohibit that. I think first and foremost, we should provide a rich benefit for those who are poor precisely because of their health status, people who are disabled, who can't work because of what's happening in their health care and because of their underlying disease. I think we should be providing an adequate benefit for them. And I think there's a lot of things states can do to move the healthier people into other settings of care where they might be able to get care more affordably. For example, move young and healthy people into the state workers program where the state workers get insured. Finally, on Medicare, we will have a reckoning in the Medicare program, and the question of how we control costs in the Medicare program is going to come down to whether government does it through centralized rules, whether we let consumers do it through choice, through exercising their choice about how they choose to spend money, or doctors do it by capitating them. And we've chosen under the Affordable Care Act to let the government do it and let the doctors do it. And the government will set rules. They're not going to set a lot of rules, but they'll set rules, and Sally talked about PCORI and other entities. But those are politically unpopular, and they know they can't intrude on every decision. So by and large, the decision that's been made is to put the onus on physicians to decide what patients should and shouldn't have and make the economic choice for patients. All the provisions that were in place that transferred risk to consumers through consumer-directed health plans have been sanded away by the Affordable Care Act, and the risk has been put on physicians through capitated arrangements. Just summing up, the accountable care organizations, medical homes, bundled payments, shared savings, all of these are euphemisms for capitation. We tried it in the 90s, it failed. We're trying it again. It's likely to succeed this time, not because it's a good model and it's going to be financially viable, but because the physicians will have no alternative. They'll have nothing to go back to.
Thank you very much. So we're at the point of the debate that's termed moderator-led debate, and we'll follow this with some questions. But I want to make a few observations before I pose some questions. The topic was Medicare and Medicaid must be drastically changed to survive the current budget crisis and healthcare reform. And I guess I haven't heard anybody speak against change. So I think we need to think about, if that's the case, then what it means to evolve, devolve, or have revolution in this area in order to provide health care in the United States. I also want to I'm going to try to be balanced in my comments, but I do want to take issue with one thing that Dr. Gottlieb said, which had to do with studies of the quality of health care, because this is an area I've looked at. And in pediatrics, at least, frequently Medicaid, quality of children in Medicaid is equivalent to or superior than that of children in private plans. Not always, but almost in all the studies, including I'm sure the ones Dr. Gottlieb referred to, private or public insurance does better than no insurance at all. So we have to think about, if we remove, what the actual comparator is at the population.
Well, I mean, there are isolated cases where you might be better off being uninsured if your cancer patient needs access to oral drugs. There are. This isn't probably the structured part of the debate. There are isolated cases.
But at a population level, and that's where the studies tend to be. But with that said, I also want to make an observation about perception and language. I was thinking about some of the discussion of profit and the discussion of costs in the healthcare system. And some years ago, I first heard the term medical loss ratio, which was a term out of managed care, which was used to represent the proportion of dollars that actually went to medical expenses. Now, you'd think that ought to be maximized or optimized in some fashion, but in point of fact, the idea was that the medical loss ratio ought to be kept low in order to maximize shareholder returns. And when we keep expenses low and return money back, we call that profit. So I think there's a value-laden nature. Without comment on good or bad, we should at least be aware of that. And I think the same thing is true when one thinks about the Medicaid program. Because there are, I think the number we heard was $145 billion, was that right? Medicaid.
It's $485 billion.
$485 billion for Medicaid. Of that, upwards of 80% or north of 80% is spent on long-term care for adults who don't have other money. So we think of it, Medicaid is thought of as a program for the poor, but it also, a huge number of dollars go and support those who are more working and middle class. And so we need to be careful about what the vision that the labels provide for us as we think about that. So those are my comments. But with that, I want to ask initially Dr. Rosenthal and Dr. Rodberg, in thinking about care and with what sounds to me like a goal of universal provision of care, the focus has been on public payment. Why is the focus on public payment rather than an enhanced system of public delivery? And if we're thinking, if we're talking about what the goals ought to be, is that a political decision or is that an optimization decision? And since we're all talking about changing Medicare and Medicaid in some fashion.
Well, that's a political decision. I think what you mean, or what I would mean by public delivery, is what is conventionally called a national health service. That is a program in which the national government funds the actual provision of services. One model is in Great Britain, another model is in Cuba. And I got my start in healthcare reform in 1974, writing legislation that would create in the United States a national, community-based national health service. It used models from everything from the Cuban health system to community health centers, the community health center movement in the United States. But politically, we were actually on the boards in terms of debating. Well, the politics in the 1970s was National Health Service advocates were debating national health insurance advocates. The labor unions were supporting the Kennedy-Corman bill at that point, which was is legislation that it was originally part of Franklin Roosevelt's program to create a national health insurance program in parallel with Social Security. But the politics of the country has moved to the right so far that we, in Physicians for a National Health Program, advocating national health insurance can barely get a platform today. So the long-term goal, I think, of most public health advocates that I know of is a national health service. But the short-term goal is at least to have the public fund healthcare to make it accessible to everyone.
Dr. Rosenthal, you want to add?
Well, I agree with that, and you also can change the delivery system. I mean, we haven't talked about that at all. There's perverse incentives now in the fee-for-service way because doctors get paid, the more they do, the more they get paid. More and more doctors in this country are being salaried, and a lot of them actually, even though they fought against it, actually like it. So that's a whole other thing. But I think we're focusing on the way you pay for health care because that's the one biggest item that would make the most difference in providing it for everybody and bringing down the cost. But there's lots of other things that you can fix, certainly.
And I'd like to ask Ms. Pipe and Dr. Gottlieb, I'm going to formulate the questions differently. One, I know there was something you wanted to talk about, Ms. Pipe, about reducing costs. So if you could explain, you had referred to the fact that you'd like to mention that during your close. So this might be a good time to do that. And then I have a question for Dr. Gottlieb about the functioning of the marketplace. But we'll do that first.
Sorry. Well, the Medicare trustees and the CBO have both shown that Medicare, as it exists now, at a cost of roughly $500 billion a year, will be bankrupt by 2024 when it costs about $1 trillion, Medicaid about $800 billion. So we've got some real problems. And as I said in the beginning, Medicare came in when life expectancy was around 65. Today, it's close to 79, 80 years of age. So we have tremendous cost pressures on Medicare. And if the program is going to be bankrupt, you know, it's going to hurt all seniors. We really need to, I think Medicare should be there for those seniors who really need help. We've seen today under Medicare, because of the reimbursement rates, docs are reimbursed at 20% below, and reimbursed 20% below what they get for treating a private patient. So we're seeing a lot of doctors say, we're not going to take Medicare patients anymore. 52% of doctors have already limited the access of seniors to their practice, and 26% have closed their practices to Medicare patients. So these are serious problems. My solutions are to move to premium support, as Paul Ryan has talked, raise the eligibility age from 65. I mean, they're talking about raising it to 67 by 2030. I mean, I don't even know if I'll be alive in 2030, but it's a slow process. And to do means testing. People like Warren Buffett should not be getting their health care through the government. They can afford to get their own. I believe that Medicare should be there for those people who really, you know, can't afford to get it. And I grew up under a single-payer government-run healthcare system, the Canadian system. We spend around 18% of GDP on healthcare here in America. Canada spends 11.4% because that's what the government says. Private health insurance is outlawed. But the demand for health care is much greater than what government is willing to supply, so you have long waits. The average wait in Canada today from seeing a primary care doctor to treatment by a specialist is 19 weeks. That's almost 5 months. Care is rationed, so if you're older, my own mother died from colon cancer because as a senior she couldn't get access to a colonoscopy, and you have lack of access to the latest treatments and procedures, which Scott talked about what's happening. The funds are drying up for medical device and pharmaceuticals. So I think we have to be very, very careful. Elizabeth and I disagree on this, but moving to a system where the government is the single-payer Medicare for all. In Canada, Madam Chief Justice Beverly McLaughlin, in ruling on the ban on private health insurance in the province of Quebec, said that the ban on private insurance is illegal. Access to a waiting list is not access to a health care. Canada has universal coverage. Everyone has a care card, but you have to face those long waits.
Thank you. And Dr. Gottlieb, you talked about the fact that many conservatives might view that the perturbations in the market created by Medicare destroy the market. I know others who are concerned about asymmetries of information, making it challenging for people to shop on quality or value, or to actually understand, even if they can't compare, what they're getting at any given place. Can you talk a little bit about, you think, how asymmetries in information impact how the market ought to be dealt with?
Well, you certainly can't have consumer-directed care and try to exert price discipline and quality discipline without giving consumers access to adequate information to make informed decisions, and we don't have that kind of transparency in the marketplace. I mean, there's a lot that we would need to do, and a lot that the government was trying to do when the Bush administration was trying to advance a more consumer-directed model. I mean, we talked about having provider-level data, which was, heretical. And the providers didn't want transparency around what they were doing down to the level of the provider, but you need that access to that kind of information. I think, what is troubling to me is that progressives right now in Washington talk about the fee-for-service model driving too much utilization. So that means that they're acknowledging that incentives, and particularly financial incentives, matter when it comes to the delivery of care and trying to steer people towards optimal decisions. So if you believe that incentives can drive too much use and excessive use and inappropriate use of medical care, certainly the opposite of that has to be true. If you put a physician in a bundled payment arrangement and force them to choose between their own salary and the provision of drugs and technology to the patient, certainly that kind of financial incentive can drive them to underutilize certain technology. And in fact, in the bundled payment arrangement that we've put in place in the last couple of years around dialysis, that's what we're seeing. We're seeing transfusion rates go up, underutilization of EPO, parathyroid hormone levels go up, probably from underutilization, I think, of calcium and some other vitamin D. So you're seeing some things in the data around those patients that suggest that doctors are utilizing a lot less of certain drugs, and perhaps in certain cases underutilization of those drugs. What we tried to do when I was at Medicare, and I think the conservative model, is someone's got to exert discipline on demand, and it's going to either be the government, in general sense, it's going to be the doctors who are capitated and have a financial incentive not to offer certain things, or the patient. And we felt that should reside with the patient, with a well-informed patient. And that meant creating transparency in the marketplace. The patients had access to adequate information. That meant helping facilitate the ability of patients to make decisions. That meant insulating patients who truly couldn't front money from the consequences of decisions. I mean, some patients just can't participate in the financial consequences of their decisions because even a $5 copay might be too much for them. But for the patients who have the capacity to make decisions and make the marginal decision to choose a more expensive treatment that might have less data surrounding it, those patients should have some skin in the game rather than putting the nexus of the decision on the government or on the physician.
Do you think that the infrastructure exists for there to be well-informed patients?
I think the infrastructure certainly exists for people, individuals, to have access to much better information. I mean, it's hard to deny that the information marketplace hasn't advanced, and it's hard to deny that consumers haven't become much more intelligent consumers of clinical information. I think that we still have barriers to transparency in the marketplace, and I think that there's a role for government in trying to dismantle those. It's very hard. When we tried to give access to hospital-level data or patient or physician-level data when I was at Medicare, you had the AHA or the AMA coming and knocking on your door very aggressively. But you can't have a consumer-directed model without having full transparency.
Okay, thank you. And I actually want to turn. Was there something specific you wanted to say?
I wanted to make two comments.
Okay, let me ask one question, and I think you may be able to write. We spent a lot of the focus about Medicare. I'd like to hear either your advocacy or what you think ought to happen relating also to Medicaid and the poor. And if it's wrapped into the National Health Program, that's fine. But I'm thinking specifically of children and the elderly in long-term care, things that are not currently covered under the Medicare. So if your side can address that, and then Dr. Rodberg, you want to make those comments, and then we have a crowdsourced question, and we'll take some questions from the. Sure.
One of the problems with Medicaid is that it was set up as a joint federal and state program. And in the context of the current recession, the states are suffering financially, particularly once the stimulus of 2009 and 10 ended. And so the states are cutting back because they don't have the money. We need to fund Medicaid adequately because, as somebody I think has said, the poor are sick. It's one of the reasons they're poor, but they tend to be a sicker population, and putting them into a system that is underfunded is guaranteed to not really work very well and to have some of the problems that Dr. Gottlieb talked about. All right? The two comments I wanted to make were one, Dr. Gottlieb talked about his experience at Medicare and said we've got to have discipline. Well, financial discipline in the spending of money and in the use of services. Well, that's absolutely true. The problem we have today is that most of the healthcare system in this country has no discipline except the marketplace. And what we are advocating when we talk about making Medicare a national program that everybody would be a part of is incorporating that kind of financial discipline on the whole medical care system, the whole healthcare system, not just that part that is for seniors and the disabled. The other comment I wanted to make is Ms. Pipes said Medicare is going bankrupt. It's just not true, and I think it's destructive to say so. What's happening is one piece of Medicare, the hospital portion, which is funded by a trust fund, it has an artificial restraint on it, which is that the hospital insurance can only use money that comes from that trust fund, and that fund can only get money from our Medicare taxes that we pay out of our payroll taxes. And the solution, and what happens in 2024, according to current projections, is that trust fund won't be able to pay all the bills. Well, there are simple answers to it. In fact, the Affordable Care Act found an answer by raising the payroll taxes a little bit on the wealthy. So they put more money into the trust fund. The solution is simple. It's to use the general funds of the federal government, which is not going to go bankrupt, just as the rest of Medicare faces no financial problem except rising costs, which are pushed by the rest of the healthcare system, which is private and inflationary.
Thank you. And Ms. Pipe, if you could take 30 seconds to make your comment, and then I have a question I want to ask all of you, and we're going to go to the crowd.
Well, I just wanted to add that, we don't have a real free market in healthcare in this country. 50% of healthcare today in America is in the hands of government, whether it's Medicare, Medicaid, the CHIP program, or the Veterans Administration program. So we don't really have an operating market. I just wanted to add to what Scott said about, transparency. I mean, the real problem is the federal government got us into this mess during World War II when wage and price controls were in. They allowed employers to write off the cost of healthcare, and we as employees get our healthcare tax-free. If you lose your job, you go into the market, you have to pay for your healthcare with after-tax dollars. But we really have first-dollar coverage. Most people have no idea what the cost of healthcare is. They may pay a small copay or part of the premium, but they think that it's whatever that is. And so when people think something is inexpensive or free, they use a lot more of it. So we don't have transparency, but the government got us into this mess.
Okay, thank you. So I want to ask everyone a question, if everybody could just briefly answer. There was some work done by the sponsors to identify questions, and this is apparently the most frequently asked question, and so I'm going to ask it, which is that all professors at Mount Sinai are required to know conflicts of interest, financial interests, and disclosures, and request that the panelists each comment on conflicts of interest, disclosures, and any major sources of funding for the organizations they represent. So we'll start with Dr. Rodberg.
I have no conflict of interest and get no funds from anything related to this.
Dr.
This is
Rosenthal?
a net outgo.
Yeah, it's the same for me. I belong to PNHP. They don't pay me, I pay them.
Do you know where PNHP gets its funds from?
Us.
From people
Membership.
who contribute.
Okay, thank you. Ms. Pipe?
And Pacific Research Institute receives a small portion of its revenue from foundations and individuals, but it's a very small percentage. And people that donate to PRI have no say in the type of healthcare work that we do.
In terms of activities that could create the appearance of a conflict of interest, because I don't acknowledge that they're conflict of interests until they become conflict of interests, I sit on the board of several healthcare companies and do some consulting work with a pharmaceutical company.
Thank you. And I would say I have funding from the federal government to do research in quality of care, which includes, though it's not limited to Medicaid, it covers about 40% of children in this country. So, thank you. Are there questions from the audience? Please. If you could speak up because they're trying to record this.
Sure. I'd like to hear your thoughts on why Tommy Douglas.
Oh, there's a mic. I'm sorry, we have a microphone. I didn't. If you wouldn't mind. So anybody else who has questions, if they can line up with the microphone as well, but you can go ahead and go first. Thank you. So if you could identify yourself and if you have an affiliation, what your affiliation is.
Hi, I'm Lori Wen. I'm with Physicians for a National Health Program, the New York Metro chapter. Short question. I'd like to hear your thoughts on why Tommy Douglas, who ushered in the single-payer universal healthcare system in Saskatchewan, which then became the national model for Canada, why was he voted the greatest Canadian of all time by Canadians if Canadians didn't like what he did?
Well, yes, Tommy Douglas is called the father of Medicare in Canada. He started the nationalization of healthcare in Saskatchewan. He was a Scottish chap. And then it spread. Actually, the Canadian Medicare system was actually fully brought into use under Pierre Elliott Trudeau, who was the prime minister from 1968 till about 1984, except for about a 6-month period. Tommy Douglas was named by the Canadian Broadcasting Corporation, the father of Medicare and Canada's greatest Canadian. I've written why I believe he wasn't Canada's greatest Canadian. The Canadian Broadcasting Corporation is the government radio and television network. It's not a private organization. I think that that the whole issue of single payer in Canada, when you have these long waiting lists for care, 19 weeks, care being rationed, a lot of Canadians come to the United States and pay out of pocket, not just wealthy Canadians, but they come. If you are finding that you are on a waiting list for an MRI for 4 months, you will come to the United States. And I have a friend who's running an illegal private clinic in Canada, in Vancouver, and he has 150 orthopedic surgeons, and he also has people who do MRIs and CT scans. And he's being sued by the British Columbia government because they don't believe there should be any private part of healthcare. Canadians wait on average, 17% of Canadians are waiting just to get a primary care doctor. And as I mentioned, there are long waits, ration care. People do come to this country, whether it's Silvio Berlusconi coming to the Cleveland Clinic. We have an excellent healthcare system. We have some problems, which both Scott and I recognize. But, I don't want to see the government totally take over our healthcare system and that we will have long waits, ration care, and lack of access. So I think Tommy Douglas did a disservice to Canadians. If you ask the man on the street in Canada if he likes his healthcare system, he will say fine, because most people don't need to use the healthcare system. But when Decima surveys those people who need specialized care, the numbers are astounding because they're very negative, because you can't get access to the type of care that you need.
Can I ask one question with relation to that? And that is, Canada's budget is about 8% lower, 7% lower percent of GDP than the United States.
Yes.
If we were to go halfway between, what do you think that would do to the wait lists?
In Canada?
In Canada, if we were at 14.5 or 15% rather than 19 or 11.
Well, Stephen Harper, who is the current prime minister, who is really, Canada is an exceptional country right now in terms of they've got their deficit under control and their debt under control, because he has reduced a lot of entitlement spending. I think what he wants to do is to allow some private health care to rise up from the bottom rather than top down. So if the government were spending more, then there would be more access. But the problem is that Canadians are taxed at a much higher rate than people in America, and people in Canada don't want to pay higher taxes for health care.
But that's an issue of priority rather than system. and system priority and values. Just a point. That's fair. That's a fair point.
well, right.
And
I
one,
mean-
that's a reasonable argument. I just wanted to.
Right, yes,
okay,
of course.
good. Thank you.
So, for most of these debates, I'm always listening and I'm always hearing about how.
Can you
where the-
identify yourself, please?
Oh, sorry. I'm Chase Feiger. I'm a medical student. So, whenever I'm listening in on debates like these, I always find it interesting that the United States is always compared to other countries in the world. Demographically, we're nothing like any other country in the world. We're nothing like Denmark. We're nothing like Taiwan. Socioeconomically, we're not the same. So I'm very curious how implementing a similar system to that of the NHS, and I lived in England for a couple of years, so I'm very familiar with their system. First of all, how are we going to pay for it? Number one. Number two, I'm curious as to how that's going to really impact the quality of care that we deliver when we have if we compare the way that we pay taxes in this country to other countries, as was just mentioned, we don't have, not as many people in this country pay taxes compared to many other countries. So I'm very curious as to, you've got a much smaller percentage supporting more individuals. So I'm curious as to how that's going to impact quality when we implement this type of plan, and how that's going to impact innovation as well, just to kind of touch upon that a little bit more. So how are we going to pay for it, and how that's going to impact innovation?
I think that ought to go to either Dr. Rodberg or Dr. Rosenthal.
Should I do it? There have been a number of studies of how to pay for it, and it's very, very straightforward. Dr. Rosenthal pointed out that if you look at the administrative waste in our current private insurance system, switching to a public system like Medicare with its very low administrative costs frees up about 15% of what we're spending, about $400 billion. And that money can be used both to pay for the care of the people who don't get it today, and for the retraining of the people who today are pushing paper and could be doing useful things in the healthcare system. The way to pay for it, there's a whole variety of ways you can think of to pay for it, because we're already paying premiums that are being paid, as Ms. Pipes pointed out, being paid by employers and by employees. A very simple model, just think about a payroll tax in which you split it, say, 4 to 5% for employees and 8 to 10% for employers. That pays for it. It's a standard way. We already have payroll taxes. We know what they are. We know how to calculate their impact on people, both the macroeconomics of it and the actual financing of the healthcare system. Paying for it is not a problem. The problem is getting the political will to actually make the change that would give us a decent healthcare system.
And Dr. Gottlieb wanted to make a comment, but I guess you have to limit it to about 30 seconds.
Yeah, the issue of the administrative costs in Medicare comes up a lot as the argument for a national health care system, and I think it's important to think about what that is. People talk about the administrative costs of Medicare, and they think about the cost of actually administering the program out of Washington, how much is spent at the Centers for Medicare and Medicaid Services. But Medicare actually foists its administrative costs onto the private sector. You think about all the things that hospitals and providers need to do to comply with the Medicare program, the fact that Medicare has the luxury of being able to back up their rules with civil and criminal penalties and send in people to audit charts and do paperwork checks on providers. There's an enormous amount of money spent by private individuals, private providers, to come into compliance with the Medicare program. You have to aggregate those costs if you want to consider what the overall cost of administering that program is. United Healthcare has a couple of thousand physicians on staff doing utilization review and things like that. Medicare, the entire program, has about 40 physicians on staff, only 20 at the headquarters, because they don't do any utilization review. They just impose rules on providers, and they send in people who are generally low paid to audit your charts. And those costs have to be factored in.
Dr. Fine?
My name is Oliver Fine. I'm a general internist practicing at Weill Cornell Medical Center, and I am also a member of PNHP. But just on your point, Scott, I cannot believe that you think it is simpler to deal with, the 20 different private health insurance companies that I have to cope with, each of them having different, prior approval approaches, different formularies, denying my claims. There are physicians in this country who have decided actually not to take private health insurance because of the complexity of the administrative process that they have to go through. Likewise, I feel, Ms. Pipes, when you say that there is overutilization in the United States of healthcare on an average basis. We have the lowest, number of visits to doctors, frankly, of virtually all industrialized countries. We have the shortest length of stay. Frankly, our system is holding people back from getting health care. We need to, in fact, enhance access to care in the United States. And finally, I'd like to ask, the other really interesting thing is, I can tell you're not a clinician, right? Because the issue, for instance, of joint replacement, which there is a long waiting time in Canada, I would agree. But I think that in part comes because clinicians decide to refer people very early. It takes me, in my practice, usually 2 years to persuade a patient to get a hip replacement or a knee replacement, okay? If I were in Canada, what I would do is refer them at the beginning, realizing that there's going to be a long waiting time. And I suspect that's what actually happens in the Canadian system. Your data frequently comes from, the waiting time data from the Fraser Institute. The Fraser Institute measures that by interviewing doctors, right? Whereas if you go by Canadian statistics, or whatever they call it, Statistics Canada, you get a much shorter waiting time because they ask patients how long they wait. It's kind of fascinating just to see the difference. And finally, I would like to ask, is the model we're talking about in terms of single payer one where we, for instance, in the Medicare program, could begin to move to allow Medicare to negotiate directly with the pharmaceutical industry? Because if we did that, I think we would begin to see lower prices on pharmaceuticals rather than this crazy system that we have now of multiple private insurers that we have to go through, frankly, for our Medicare beneficiaries, the Part D of the program. Is that, Len or Betsy, one of the ways in which we could illustrate the power of a single-payer system to actually also save costs?
It's ironic because the Medicaid program does negotiate and gets drugs at half the price of the Medicare program, which doesn't. So we actually have empirical evidence of what the ability to negotiate would achieve for the Medicare program.
And I want to second what Dr. Fine said about the complexities of dealing with the insurance companies. Most of those doctors who don't take Medicare don't take any insurance. And here's what happens when you bill an insurance company. This shows how many people they have working there. You bill them and you never get paid right away. They always make you resubmit and resubmit and resubmit, and then after 4 months that you've been doing that, they say, oh, well, I know we're contractually obliged to pay you, say, $100 for such and such, but if you will agree to take $70, we'll pay you now. That's what they do. Medicare actually pays you. So even though theoretically private companies pay more, they really don't because they don't actually pay you.
Okay, and I want to give Ms. Pipes an opportunity to answer as well.
Well, in Canada, so in Canada, you can't call up a specialist. You have to go to a primary care doctor. We call them general practitioners. You get an appointment, and then they refer you to an orthopod, if that is the thing. It takes about 4 months to a year to get an appointment with an orthopod, and then you have to wait a year to 2 to get your knee replacement or your hip replacement. There's a lot of cost of waiting in pain. And I know in Canada, a lot of the treatments that are done here aren't even available in Canada because there isn't enough money to update the various equipment and procedures in Canadian hospitals. I wanted to say that also that, Medicare, remember the president, when he gave 59 speeches on healthcare reform, he talked about the fraud and abuse in Medicare. The RAND Corporation has said fraud and abuse in Medicare last year was about $98 billion. The General Accounting Office said it's about $44 billion. So, there is a lot of fraud and abuse in a program run by the government. And so why would you want to go to more of a government run system than we already have? And in Canada, doctors have to submit their claims to the provincial government in which they are in. Now, so it takes, my cousin's an ophthalmologist. He does corneal transplants. He waits a long time to get paid by the BC government for the procedures that he does. And the second thing is, in mid-November, his global budget for what he does is used up. There's no more money from the government in order to do that. So he goes on vacation because he can't get paid. So I think we have to be very, very careful. Do you want government to run your healthcare system, or do you want individuals and doctors to be in charge of patient? And both Scott and I believe in consumer-directed choices for our healthcare system.
Sally and I were joking that next time we'll bring people from our organization. I only brought my wife tonight, so I should have brought people from... I'm not sure how you set up your office or why you're doing business with 20 different insurers, but the bottom line is I think that there is a real argument to be made for standardization in terms of how we go about billing. And I think that the government could play a role in doing that through effective regulation. And in fact, there's things in the Affordable Care Act that I think might work to help standardize billing systems and make it administratively less expensive and easier on practitioners who do want to stay independent, although most of them are consolidating. On the drug issue, I mean, this is a long, complex debate, and I will just scratch the surface. 80% of all drug utilization in the country is now generic, so we're really only talking about 20% of the drugs that are actually branded drugs. Only 10% of overall spending on healthcare is on drugs, and that includes specialty pharmaceuticals and generics. So it's a relatively small portion that's spent on branded drugs, maybe 5% we're talking about, maybe 6%. I mean, I'm not saying that that's a trivial amount of money, but that's what we're talking about. The question comes down to, how much profitability do you think it's going to take to attract the risk capital to engage in these very high-risk scientific endeavors? I don't know what the magic number is. I know that the system we have right now seems to be working. I know what the number was in healthcare services because it was what we did away with. So we know we went too far in sanding down the profitability in that sector. And I hope we don't do that when it comes to medical technology.
Thank you. I want to say we're not going to we'll take the questions of the people who are standing, but we won't take any additional questions. And I'll make one observation with regard to the notion to the statistics regarding fraud. And that is that one of the insights that recent looking by Medicare into fraud, and Medicaid as well, is that most of the fraud is actually due to vendor fraud. It's not due to the beneficiary fraud. The vast majority. I mean, beneficiary fraud is not rounding error in that. It's still a substantial number. We don't know what the number is in the private sector, but just to clarify what fraud means in that context. Well, vendors can range from hospitals found overbilling. It could be vendors and sellers of durable medical goods who receive prescriptions from physicians and don't provide services. So there are a number of different sorts of things. It can be small business, it can be large. But it doesn't tend to be at the beneficiary level, and I think that's the most important observation.
But also there's a lot of doctors who have been charged with fraud in Medicare and over billing for a lot of people that they didn't actually see or could never have seen that many people
That's absolutely correct. So I would consider doctors to be vendors as well. So it's small, large, and everything in between. Please.
My name is Rosenthal. I'm a physician, member of PNHP, and I'm related to one of the panel members. Everybody agrees that the costs of medical care are terribly high and rising, and that it's a terrible problem. You can look at that as there are really two aspects of that. One aspect is the cost of the actual delivery of the medical care, which is really a very difficult question to go into. But another topic you could discuss is the distribution of medical care. If we took away Medicare, then the costs that people are paying would not go away. The cost would just be shifted to somebody else. Individuals would have to pay their medical bills. If we took away Medicaid, the cost wouldn't go away either. People without insurance would go to emergency rooms. Their bills would be subsidized by everybody else's. Their bills and people without Medicaid would be paid for by consumers whose bills would go up, by subsidies from government. So my question is, since it's been shown in every major industrialized country that government, either government controlled or government regulated distribution of medical care greatly reduces administrative costs. I mean, it's a fact. It's not something which is subject to discussion. How can anybody defend the continuation of our chaotic system of privately distributed medical insurance for profit in this country?
If I could ask one of you to take that, just in the interest of time.
Well, I'm not sure it's a fact that the government-run systems are administratively less expensive. In fact, I don't think it's a fact in this country. I think Medicare is an expensive program to administer. Nobody's talking about doing away with the Medicaid or the Medicare program, the commitment that they made to individuals, and certainly no one on the conservative side is arguing that. The reality is the insurance companies now have their profitability capped, and I think that that's going to be a real problem because when a new insurance scheme enters a marketplace, it operates at a high profit margin. That profit margin erodes over time. Down to about a 15% profit margin, sometimes less than that. By capping the profitability of an insurance company, you're basically benefiting incumbent members and making sure nobody new enters the market. And so that's what we're going to see. I would just make a final point. I think on the cost of delivery, I think that that's really the conversation we should be having around the cost of delivery and what we've done under the Affordable Care Act and what we could do, what might be an alternative to the kinds of schemes that we put in place to try to bring down delivery costs. What we've done essentially in the Affordable Care Act is given very strong incentives to hospitals to consolidate physicians as salaried members of those hospitals on the notion that the hospitals can invest in systems that will lead to better coordination of care, and that the government can impose regulations on those hospitals to try to control what doctors do and capitate those physicians and give them financial incentive to watch what they do. Because it's very hard to regulate individual physicians from Washington, much easier to regulate the entities they work for. I think this is going to be a real problem. I think there's a lot of problems with it in terms of its ability to lower the cost of delivery of care, not least of which is I have an article coming out later this week, hopefully in one of the newspapers, talking about productivity and what happens to physician productivity under these arrangements. And it goes down quite dramatically, as much as 25% if you look at the data. And so if you believe that diminishing physician productivity by 25% across the board is going to lead to lower costs or better outputs, that's simply not going to be the case.
Good evening. My name is Annette
I think
Gardino.
Dr. Rodberg.
Let me just make one comment. I mean, I'm glad that Dr. Gottlieb thinks no one is proposing, on the conservative side, is proposing doing away with Medicare, but Paul Ryan did today. In fact, in his House budget, proposed that for anybody who was 56 and below, when they turned 65 or 67, they would have no Medicare. They would have a pot of money with which to buy private insurance. That is not Medicare, and it does not have all the features that Dr. Gottlieb is talking about in terms of federal regulation of the provision of care that already exists within the Medicare program.
He's basically proposing Obamacare for old people. I mean, that's the simplest way to think about it, is what he's proposing.
Yeah.
Well,
Yeah.
Good evening. My name is Annette Gaudino, and I'm a concerned citizen, and I'm also a speech language therapist in a skilled nursing facility, do short-term rehab, and I work with long-term care patients. So I'm aware, and I actually do the billing and the documentation to bill Medicare and to bill private insurance, and also for Medicaid. First, I have a comment. There was a gentleman who asked a question and talked about the National Health Care Service. The National Health Service is actually the VA. National Health Care Service is a government-run system where everyone is a public employee, like the Veterans Administration, and really is not what Medicare is. Medicare is a single-payer system. I think it's important that we recognize the difference. It's a very important difference. My question is, similar to it's along the lines of the previous question, which is every other developed country has no profit in their healthcare system. You know, there are countries that do it using private insurance companies. There are countries that do it using direct public funds, single payer. There are countries that use a national health service where everyone's a public employee. But all those countries, the thing that's different from our system is that there's no profit in it. You know, you're not talking about publicly traded companies who are heavily involved in the provision of healthcare. We are the outlier in that. Given also that we are the outlier in terms of cost, both in terms of GDP costs and per capita costs. Our per capita costs average about twice what the average is for the OECD. And given our healthcare outcomes are worse across the board, whether you're talking about, you know, infant mortality rates, you know, a whole host of issues are worse, again, compared to the OECD. I'd like the panelists who are in the pro position to name a specific instance, historical or current, in which expanding market, the play of the market, the free market, the for-profit market, in health and in healthcare provision or delivery has resulted in cost containment or lowered costs. I would point, the example that comes to mind for me is the Medicare D expansion, the drug expansion, which is actually exploded costs. One of the huge explosions of costs for Medicare is a direct result of a market-based reform. So I'd like to hear from them a market-based reform that they know of that actually
Okay, I think we've got, thank you for the question. Who would like to answer?
We're both going to answer.
I'd ask you to make it brief.
I mean, yes, yeah, of course. I mean, the OECD, WHO, Commonwealth Fund are always coming out with these studies saying, you know, the United States life expectancy is lower than in countries like Canada and Morocco and Cuba and things. Well, because these studies are, what they ask is, does a healthcare system treat people equally rather than does it treat people well? And people, as I said before, people come from Canada, they come from all over the world. We do have an expensive healthcare system, and we're spending about $2.6 trillion. But the United States is a very wealthy country, and Americans demand the very best in healthcare. So when you're looking at life expectancy, you have to compare things like deaths, homicides, car accident deaths, obesity. And when you, on a per capita basis, work that out, the United States actually comes out number one. In terms of cancer survival rates, the United States ranks number one in the world in terms of cancer survival rates 5 years after diagnosis. Those are statistics that are important. On infant mortality, some countries in Europe, a live birth is only if the birth is a certain weight and a certain length. We have incredible neonatal units in this country and allow these babies that wouldn't even be live births to survive. A woman in Canada, in Calgary, was expecting quads in 2008. There wasn't a single neonatal unit in Calgary, in Alberta, or anywhere that could deliver those quads. She was flown to Great Falls, Montana, a city of 55,000. Her quads were delivered, and she said, thank heavens that I had that escape valve, the United States. So people have to be very careful. I did a Wall Street Journal piece on this issue on international statistics about a month ago. I mean, you know, treating people equally rather than well does not mean you've got a great healthcare system. And I ask how many people, I don't want to go to Morocco or to Cuba for my healthcare treatment. I want to make American healthcare affordable, accessible, and quality care.
And Dr. Gottlieb, if I could ask you to focus on the cost component, which is I think where the question was headed, where in an international example of improving cost curves, embedding the cost curve with a market solution.
I think it was a domestic example. I would put forward.
Or
I would put forward Part D and Medicare Advantage. I mean, you look at the drug companies will tell you that they're getting less money for certain drugs under the Part D system than they make on their products selling them to European nations. And Part D has driven down the cost of drugs to senior citizens, in fact, well below the estimates that the government first put out, we first put out when I was at the Medicare agency. And the same thing with Medicare Advantage. And the government's reclaiming a lot of their savings. The Medicare Advantage Medicare Advantage plans have achieved savings to the program. And the actuary of CMS has acknowledged that, and so has Congress. I think what will suffer most if we do away with the profit incentive in healthcare, though, is going to be the technology. You don't see the investment in new technology in other countries. And it's an open question what the right level of profitability is to sustain the level of investment that we have in new technology in this country. I don't know what that answer is. I know what we have right now works. The government's certainly not going to be able to do that. You're not going to be able to do it through NIH. The government's not going to be able to pick and choose winners and investments in technology and which things are going to succeed and which things won't. It becomes exceedingly politicized when the government's tried to do that in the past under programs like BioShield and with some of the president's clean energy initiatives. So I think when you take the profit motive out of healthcare, you're going to see less innovation, not just in the delivery of healthcare and healthcare services, new ventures, new ideas, new ways of organizing care, but also in medical technology.
Thank you. And if I could ask you to make the question brief and focused.
Okay. My name is Edwin Holman. I'm a medical student. My question is a little bit more narrow. There's some points brought up about sustainability of the public health insurance programs, specifically Medicare, and you spoke about the differences in life expectancy between now and the time that Medicare was enacted, and you used life expectancy at birth as a statistic for that, and that seemed a little curious to me because Medicare, what really matters is I would think the life expectancy upon attainment of working age, so like say from age 20. And so if you compare that, it's only gone up it hasn't actually gone up that much, and it's higher than you think. It's about age 73 was the life expectancy for a 20-year-old in 1970 versus 79 now. So 73 to 79. If you compare ages 65 to 65-year-olds, on average at that time, they lived to age 80 in that time, and now 40 years later, they live to age 83. So we're not talking about huge differences here. So I don't think that demographic side of it can really explain the sustainability of these programs.
Well, as I said, Medicare in the first year cost $3 billion. In 1990, it didn't cost $12 billion. It cost $110 billion. I'm part of the baby boom generation. A lot of us, there's going to be a huge watermelon going through that snake of people who are going to be eligible at age 65 or, starting in 2022 up to age 67. So there's going to be tremendous cost pressure on Medicare. And as I said earlier, a lot of docs, because of these lower reimbursement rates, the sustainable growth rate and all of this, are not going to treat people on Medicare. We're going to have a lot of people. So why not make the system work according to to means test it so and premium support is different than a voucher. Premium support is like under Medicare Part D, where there will be private insurers in a federal exchange, and then you can decide what insurance you want, and depending on your level of income, you will get a subsidy. Your health insurance will be subsidized. I mean, this is the way to make the system more sustainable, because we can't add all of these baby boomers when we know the system, the spending on Medicare and Medicaid are both out of control.
I think one important point that you heard there was that this ballooning is in part an epidemiological phenomenon, which also means it's a time-limited phenomenon. So it's not that the costs are going to continue to grow ad infinitum, but at some point, as we get to the end of the watermelon, as Ms. Pipes very colorfully described it, that those costs will come down to some extent, but the longevity and the increased intensiveness of care that's delivered have also contributed to increasing that. Thank you. If we could have the next, this is the last question.
Hi, my name is Riju Banerjee. I'm a second-year medical student here. I have lobbied for PNHP in the past, but I'm still trying to define my position. So my question to actually the entire group, and I just wanted to thank you all for coming here and speaking for us, is, we've talked a lot about Medicare and Medicaid, but we haven't really talked all that about in your own proposals what sort of the role of private insurance will be, sort of going forward in the future, such as in a single payer versus a market-based plan. So if you could elaborate a little bit about that as part of your closing remarks, that'd be wonderful.
Thank you. And if I could ask each table to maybe take a minute to answer that question. What the role of private insurance would be in the PNHP vision.
Well, in my model of it, there would be no role for private insurance that would compete with Medicare. Just as when Medicare was first set up, it was private insurance that provided the same coverage as Medicare was not allowed until the new Medicare Advantage program was created. I think the term premium support, which is used to which Ms. Pipes used, means buying private insurance. I mean, let's translate the word into what it means. And the notion that we will improve the American healthcare system by moving from an efficient public Medicare system to an inefficient private insurance system seems to me totally misguided.
Thank you.
Well, I think I would envision private coverage being a more prominent part of Medicare. I think the Medicare Advantage plans have provided savings to the program, and in many cases have made services available to patients that they're not getting under normal Medicare. If you look at the people who are enrolled in Medicare Advantage programs, it tends to be lower income Medicare beneficiaries, precisely because the Medicare Advantage plans are able to wrap around and offer things that that traditional Medicare does, unless you go out and buy a Medigap policy to wrap around Medicare. I think, the Paul Ryan plan is basically just Obamacare for Medicare beneficiaries. It's the easiest way to think about it. And I think with respect to the federal exchanges under the Affordable Care Act, the idea of having a state-based exchange to purchase insurance is a sound idea, creating a central marketplace that creates efficiencies for consumers to go in and buy coverage, subsidize certain consumers through those exchanges if they don't have the ability to buy coverage for themselves. I think for conservatives, what really is the offending element in that plan, if you will, is the federal regulation that drastically limits the choice of the kind of plan you can buy. It's essentially one plan. The president talks about the bronze, silver, gold plan. Basically, they all just vary in terms of the copay structure, but the benefit structure, the networks, everything else is going to be the same. And so you really don't have a choice under the Affordable Care Act. It's going to be a heavily prescribed government plan, much like Medicare. It's just one plan with different copay structures.
Dr. Rosenthal, do you want to?
Yeah, I have to take issue with what you said about Medicare Advantage. I counsel people all the time. The people are poor who take Medicare Advantage because they cannot afford a Medigap policy. A Medigap policy really covers them very, very well. Medicare Advantage has high copays, high deductibles. If you're not very sick and you're poor, you can do very well with a Medicare Advantage because it's less expensive. But if you're sick and you're poor and you can't afford a Medigap, you really get messed up when you take a Medicare Advantage plan, because you are unable to pay the copays and the deductibles, and if you have several hospitalizations and see many doctors, you're just totally at the mercy of these private plans, and you can't afford your health care.
Worth noting, the president's about to tax Medigap policies to discourage people from having them.
I think I'd like to leave it with that comment. I think we can take from this that whether the changes are drastic or not, there certainly are needs for changes. There's also different ways to view and summarize and synthesize this, and there are legitimate and thoughtful positions which come out favoring larger and smaller roles for private and for government in this. I think that I hope this has been important food for thought. I'd like to take a moment to thank the sponsors of this, the Benjamin Rush Society and the Mount Sinai chapter of AMSA, the American Medical Students Association. And if I could ask all our panelists to rise so that we can give them a hand, and then I'll turn it over to Joe to close it.
I'll keep this short, sweet, and slow. I'd like to, again, thank all of the panelists for coming, Dr. Kleinman as well for moderating. I'd like to thank everyone here for coming as well and for keeping such a polarizing topic relatively non-confrontational. I'd also like to thank Carlo for all the hard work he put into this event and setting everything up, and also Larry Gaiman over there, who's part of the Benjamin Rush Society with me and who also put in a lot of hard work into setting this up. So thank you, everybody.